Okay, this is still Good Morning Nigeria on the network service of the NTA. Let's now turn our attention to cancer. Now, the cancer burden on Nigeria is quite, huge, and the disease, accounts for 13% of all deaths in the country.
Actually, about 15% thereabout. Now, that's actually true, Victor. And the most common types of cancer in Nigeria are breast, cervical, prostate, liver, and colorectal cancers.
Well, cancer incidence and mortality rates are increasing in the country due to the growing population, aging, urbanization, changes in lifestyle and diet, as well as limited access to screening and early detection.
Cancer is a difficult disease, so don't blame me finding it difficult to call that. Now, data on cancer has been a major challenge in Nigeria due to inadequate cancer registration and data collection systems, limited availability of reliable and up-to-date cancer data, of course, in so many areas of concern, as well as underreporting of cancer cases and deaths. And of course, you want to talk about the lack of standardized cancer data collection tools and protocols. It's a whole mix.
So as Nigeria grapples with the rising cancer burden, access to accurate and timely data remains a significant challenge. Inadequate records and lack of awareness have hindered effective diagnosis, treatment, and policy making. But it's important to mention that the World Health Organization offers cancer data and statistics for Nigeria, while the Nigerian Ministry of Health publishes occasional reports on cancer data and initiatives.
Key statistics on cancer in Nigeria estimate that in 2020, 115,000 new cancer cases were reported annually, with an estimated 70,000 cancer-related deaths annually in the same year. Now, cancer incidence rate indicates that about 120.2 per 100,000 population in the year 2020, and cancer mortality rate of 90.7 per 100,000 population in the same 2020.
And one thing to note is that data may vary depending on the source and year. We'll examine the role of technology, advocacy, and policy in enhancing cancer awareness and care.
Join us. We have joining us to speak on this, Professor. All right, we're supposed to have the DG of NICRAT, but due to some other pressing issues, he's unavailable. But we have with us Professor Musa Ali Gombe, the Director of Clinical Services, NICRAT. Many thanks for joining us.
Good morning, viewers.
And we have also been joined via Zoom from Bauchi by Professor Sani Malami, Director of Cancer Surveillance and Monitoring of NICRAT. Thank you for joining us.
Good morning.
Well, let's begin from here in the studio. Professor Ali Gombe, where are we? We do know that most people it's almost like a death sentence. When you hear that someone has cancer, people begin to say, yeah, because it leads oftentimes, to one end, death, no matter how hard, no matter how much you have, by the way. But where are we, and how can we begin to ensure early detection so that more people can survive cancer?
Okay, thank you. Before I go to your question, I will want to tell the viewers a little about the institute itself. The National Institute for Cancer Research and Treatment, which is NICRAT, was established by the establishment NICRAT establishment of 2017. However, a substantive DG was not appointed until February last year. So it's a new institute that is, some people may not be conversant with it. And what is the mandate? The mandate is, the NICRAT is majorly created to take leadership in cancer prevention, diagnosis, treatment, and control in general. It also has the mandate to liaise with anybody in the cancer space in Nigeria to coordinate and also execute the implementation of cancer projects in the country. In short, the vision of the Institute is to take leadership in not only Nigeria but also in Africa at large. So cancer is not a death sentence, actually. However, for most cancers, one needs to present early. That is why screening is very important. Early detection saves lives because cancers are in stages. Stage 1, 2, 3, and 4 in most cases. So stage 1 and 2 are called early cancers, while stage 3 and 4 are called late cancers. So early cancers, the chance of cure is very high. It's usually range between 70 to 90-something% depending on the type of tumor that one has. And also, for the late advanced cancers, the chances of cure decreases. However, irrespective of the stage of the cancer, the chance of cure is still there. And I can tell you that there are even stage 4 cancer patients that have had cure. However, screening is a very important tool. When you look at the burden of cancer that we have in Nigeria, if we will be able to screen early, it is more cost effective and it will reduce the mortality of cancer that we have. So what is the Institute doing? The Institute has a dedicated department, which is the Department of Cancer Prevention and Control, which is had the responsibility of screening and early detection of cancers. The Institute has gone ahead to design and plan some screening programs for the country. We have observed that, one, there is need for advocacy. So people need to know what is cancer and demystify the myths, that people have about cancer, and also take advocacy to other stakeholders in the cancer space. And another factor is collaboration. You need to collaborate both locally and internationally for you to succeed in cancer screening and cancer control in general. The other aspect also is in terms of what do you do for screening. Currently, there is no comprehensive national screening guidelines and comprehensive national screening programs in the country. So we are already developing a national screening guideline, most especially for the common cancers, breast, cervical cancer, and prostate, and then cancers of the children, as childhood cancers or pediatric cancers. And also, we have identified that there is need to do a two-pronged approach to the cancer screening in the country. Based on the tertiary institutions that do treatment of cancers across the country, which are at least you have at least one in each geographical zone, that can be made to be the hub for cancer screening at the tertiary level. Meanwhile, we have also designed a mobile clinic, which we are trying to launch for screening into the population, whereby you can go to the community and screen based on some criteria. Probably you may decide to choose maybe the market days, for instance. So the mobile clinic is a van that will be equipped with the screening tools, equipments that are required for screening the commonest cancers like breast, cervix, and prostate. That goes into the community, screen, and then returns the sample back into the laboratory. But another dimension to it also is the personnel, that we require for the screening. Apart from the supportive staff, the specialists that will interpret those screening results, such as the radiologists and also the pathologists, are actually very few in the country. And so we also thought that deploying artificial intelligence as a component of the screening can also assist in reducing the burden for those few pathologists that we have, or radiologists in the country, because that will AI can be used actually to select which patient goes for review by the doctor and then which patient does not require review. The other aspect is also to take the screening at the primary care health level. So there is also need to train the primary care staff in terms of detection of early symptoms and signs of this common cancer so that they can navigate the patient appropriately to where the patient can receive treatment.
All right. Many thanks, Professor Gombe, for your opening remarks. Quite detailed. Shows that NICRAT is doing a lot. But let's get to Professor Malami, Director, Cancer Surveillance and Monitoring at NICRAT. Prof, I want you to, take off from where Professor Malami, stopped and tell us about the challenges, around cancer in the country at the moment. We want to know, is it the lack of personnel, like Professor Gombe had mentioned, or is it the lack of infrastructure, to deal with it, or is it an issue of culture, people wanting to run away from saying, oh, well, I can't have cancer, and, not wanting to present themselves to medical personnel and all of that for screening and treatment. Just let us know, why are the numbers rising and the factors responsible?
Thank you very much for that question. My colleague has given a very good background as to the cancer problem in Nigeria. Specifically, to respond to your question, cancer is a multi-dimensional challenge in Nigeria, in the sense that it continues to rise. Our approach as a nation, as various communities, as professionals, have clearly been ineffective in this. Over the past decade, we've seen a steady rise in the number of cancers in Nigeria, and which is unfortunate in the sense because, of course, we have a very weak health system. We have limitations in terms of resources in Nigeria, which Professor Gombe has mentioned. Personnel, equipment. The whole gamut. So, talking about cancer, one has to approach it from this perspective. We're in Nigeria, we know our limitations. So, what can we do? We know for a fact that about 30% of these cancers can be prevented by just adopting lifestyle changes, avoiding certain exposures and the like. About 30% can be prevented by detecting them early and treating, and then the other 30% are amenable to various forms of treatment. So it's not, as my colleague has said, it's not a death sentence as many people assume. And this is the information we need to get out there. Let people know that cancer can be controlled, and there are various steps being taken by government and other partners to see that this control. But we need the cooperation of the society itself. We need to marshal our resources to consolidate what we are doing in very many ways. So talking about cancer as a disease, most people assume that cancer is a disease like probably like typhoid. Say this is typhoid, is caused by so and so, or bacteria. This is not the way cancer is. Cancer itself is a range of many diseases. Cancer that affects for instance, the breast is very, very different from the cancer that affects the brain, or affects the bone. In terms of the position, in terms of how it manifests, in terms of the effect it's going to have on the individual, in terms of the ways to approach it and treat it. And so the investment has to be, in order to approach, to treat it, the investment has to be a targeted kind of one, a knowledge-based. There is a lot of things that come into that picture before we're able to approach cancer. So one of the is where we are lagging behind as a nation is in terms of data, which is the subject of our discussion today. We don't know for a fact what we are treating. We don't know how many cancers. We don't know who is being affected. We don't know where people have been affected. We don't know how they are being treated. We don't know how they are responding to this. So apart from the fact that we have a serious problem, a problem of equipment, a problem of personnel, the right skill sets, the right infrastructure for the treatment. We also, unfortunately, do not know, we do not have that data.
Lost connection with Professor Malami temporarily. I hope we get it better and we reconnect with you. But let's get back here in the studio. Now, Professor Malami had talked about data being an issue, but I'm also looking at screening, because if we say we can, like according to him, 30% can be dealt with early screening. So how many screening centers do we have across the country? And what are the plans to improve this so that, because the more people can get screened randomly, then you will know, oh, this person has a cancer that he himself or she may not even know about. So how many screening centers do we have, and what are we doing to maximize this?
Well, thank you for that. The issue of screening and data are separate things, but they are related. But let me answer your question first before I talk about the data. So in terms of screening, what is obtainable today in this country is that we have hospitals across the country in almost each state and major cities across the country, whereby if you want, you can willingly walk into these centers and ask for a screening.
How affordable? How affordable?
Well, it depends on the type of screening. Some screenings are more affordable than others, depending on the sophistication. And, for instance, screening for prostate cancer is a blood sample that is taken, and then an examination also. A physical exam is done to the man who presents himself for a screening of the prostate cancer. It's relatively cheaper when you compare to a mammogram for breast cancer, which is required for women over the age of 40 years to do yearly as screening too. So it depending on the hospital. Mammography machines are usually found in tertiary hospitals and some private clinics and diagnostic centers across the country. So screening is now done based on a hospital basis, not like a national coordinated program for cancers. And that is what I was mentioning earlier. There is need to coordinate it centrally and make the screening, a program whereby, anybody that wants to be screened can walk into a hospital. So what we did is to designate some hospitals across the country, whereby we will do preventive oncology clinic. So those preventive oncology clinics are going to be responsible for screening, whereby if you just walk in, you will can request for screening for any type of cancer, and there are doctors, nurses, and other staff available to screen you. And we will also equip those centers with those necessary equipment and other things that are required for the screening of those centers. So that's for the preventive oncology clinic. The other aspect of screening also is you have to reach to the population, because if you stay in the hospitals, most people will not want to come, probably for several reasons. It's expensive to make the journey to the hospital probably, or their schedule is too tight to actually allow them come. Since they are fine, they may feel it's not necessary for them to come to the hospital for any screening. So it's also good to take the screening to the population. So that is why you have to go to the community, where people are working, to the villages, in their farms, and to marketplaces and other places necessary to conduct those screenings.
Now, listening to you, Professor Gombe, who do you want to blame for the lack of data? Because you have mentioned the fact that, well, individuals cannot, be available at medical facilities all the time. The cost of doing the screening, of course, is also another issue. You're the ones who wants to blame personnel, because sometimes they're a part of this problem. Sometimes patients present, or rather get to them, and they're not able to detect that they have cancers. They keep pushing them up and down, treating all kinds of ailments before, eventually at a later stage they get to realize. So it's a whole chain. So how do we get this data issue right in a country where even the population of its people at the moment was still, just speculating?
Well, when NICRAT came above and the DG actually, he swung into action, and the first thing that we did was to do a gap analysis. Where is the problem with the data in Nigeria? So we identified some very important factors. One is the issue of ownership by government. The cancer data needs to be owned by government. In the past, what happens is that some individuals have made very good attempts to get grants to support those cancer registration in Nigeria. However, it's not led by government. It is led by private individuals, and it's not housed, in government facilities. So, what we did was to make the headquarters. We dedicated a section of the headquarters of the National Institute for Cancer Research and Treatment as the National System of Cancer Registry headquarters, whereby all cancer registration data will be pulled to that National System of Cancer Registries at the headquarters. This has already been launched about 3 months ago in NICRAT. And also, we identified that the number of population-based cancer registries that we have. Cancer registries can basically be population-based or hospital-based. So most of the data that we are getting from the country right now is gotten from hospital-based cancer registries. They only record those patients that come to the hospital and are diagnosed with cancer. They are not going into the population. We have about 13 population-based cancer registries across the country. So these population-based cancer registries are supposed to be equipped to go into the population and take cancer data from all patients that are diagnosed with cancer. So that we have identified, and currently we have started equipping those population-based cancer registries to make them stronger so that they can have all the facilities necessary to do that. The other thing is also about the training of the personnel. We have also identified that a large number of parents are not well trained there is a system, there is a software, there is a coding system, and the way you also fill in those informations is standard. So there is need to also train those people. So what we did was to do a national population based cancer registry workshop, whereby we invited very important and personalities from across the world who are renowned in cancer registry data. Notably is the head of surveillance of IAC, that is International Agency for Research on Cancer, Freddie Bray, and also Professor Max Donald Parkin of the African Cancer Registry Network, who is very popularly known as the main person behind most of the cancer registration across the world. So they came to the cancer registration workshop in Nigeria, whereby they now step down some of this training to the directors and other staff of registries. We invited them to Abuja, where we had that workshop. And at the end of the workshop, another thing that we also identified is that people are reluctant to report cancer data. So there is also need for regulation to allow reporting to make the reporting of data compulsory in the cancer data. Because I may be in my clinic and I diagnose cancer, if there is no regulation, I don't owe anybody a duty to actually report this information that I have diagnosed this cancer patient in my clinic. Mm-hmm. So the Honorable Minister of State for Health, at the end of that cancer registry workshop, launched the cancer registry data regulation and also declare cancer a notifiable disease. So it is now compulsory in Nigeria when you diagnose cancer to report it. So that will also improve the cancer data. The other aspect that we also identify is in terms of infrastructure. Of course, if you want to do a population-based cancer registry, apart from computers, space for the staff in the hospitals whereby the registry can reside, there is also need to have mobility cars or any other means of transportation for them to go into the community. Somebody has to pay for all those things. So these are things that we are trying to bring so that these people can be able to go reach out into the community and get those information for us, which can now be centralized into the cancer registry data. Another problem that you identify, which cannot be solved at NICRAT level, is the issue of population, the census. Because what is currently available, if you look at the recent data that was released by Globacom, it's actually, they use the 4 population-based cancer registries in Nigeria, and then they want to do an estimate. But that estimate will have to depend on the population that you have. Since we don't have a recent population data, it becomes difficult to have an accurate estimate that you want to do. So that we have started advocating and reaching out to the players in the population space to also, move so that we can have a national census that can also help in having more accurate estimates for the cancer data in the country.
All right, thank you very much, Professor Ali Gombe. Let's get back to Professor Sani Malami, who I understand is back well connected. Professor Malami, I was just wondering, while your colleague spoke with us, to what extent do you deploy technology in your operations, and to what effect?
Yeah, thank you for that question. Nigeria, and in fact, the world has moved on from the days of manual registration. Now, people are able to record data on cancer precisely, accurately, and also in a very effective way, and they're able to disseminate this kind of information in real time. For instance, part of the initiatives by NICRAT now is that we have set up a national database which can be accessed at any point from anywhere in the world. So technology is playing a great role in the evolution of cancer registration. Now in other countries, and we're hoping to reach there soon, people are able to report using their Android phones. They're able to report from very remote locations. They're able to collect data from in very vast countries like India, where they have hundreds of cancer registries, and these cancer registries collect information from thousands, literally millions of clinics and hospitals. And this is done, of course, not manually, it's electronically. We have a software, which is an open source software called the Courage software, which is a software that has been developed by the World Health Organization, WHO, and it is compatible with most devices, Androids and other iPhones and the like, and it's compatible, it can be used offline and online, and it's such a robust software, and now it has been deployed across Nigeria. We previously had the earlier version, the Courage 4. We moved on, now it's the Courage 5. All our cancer registries to be able to use the Courage 5 software. In fact, it's in recognition of the importance of technology in the work we do in the cancer registration space that IRAC, that is the agency of the WHO, which is in charge of data registration, is in the process of training 2 of our registrars in Lyon, France, and the training will start in October. They are going to be trained as master trainers on Courage, which is the top technology software for this. In addition to that, we're looking beyond what we're doing. In the near future, the Honorable Minister of State will be engaging with a Progressive Cancer Center in the US to explore also how we can use technology not only to have the data, the numbers, but also to be able to save the images, digital images of cancers, to tie them up with this. And this will give us a comprehensive picture of what we're looking at. So technology is playing a big role in our advancements. It's going to occupy a big space of what will be done, and technology is in fact going to dictate how the evolution of cancer registration is going to be now and in the near future. But the government is investing a lot in this area, and our partners will also be investing quite a lot to deploy technology into the cancer registration space.
All right. Thank you very much, Professor Malame, Professor Gombe, Ali Gombe. You have mentioned so much that NICRAT is doing, and then you did mention that it's a new organization and all of that. We understand the challenges that it could be, but tell us what are the challenges facing cancer research and treatment in the country at the moment. Are we thinking homegrown solutions, or what is NICRAT looking at?
Okay. I'll still go back to the issue of data, but now not only on cancer patients or diagnosis, but also what resources do we have in cancer. Based on that, the Honorable Minister of State for Health last year, November, has written to the National Atomic Energy Agency requesting an impact review to be conducted for Nigeria. The impact review mission actually is supposed to assess our resources, in terms of cancer prevention, cancer control, cancer diagnosis, and treatment. And then it will also make recommendations so that at the end of the day we'll have a bankable document which we can use to inform the national cancer control plans, and also use it to see where we can invest in cancer care. So having done that, the minister also went ahead to inaugurate the national focal team for the impact review mission. The national focal team has been inaugurated, and the impact team, focal team is also working with the international team of experts and the IAEA on the impact review mission. The impact review mission is scheduled to take place in October, between 14th to 25th of October. However, there is a lot of work going on already. There are some self-assessment questionnaires that we have been distributing across the country to assess human and other oncology treatment resources across the country. So this is in preparation for the impact review. The expert teams will come and they will visit cancer treatment centers and other cancer-related centers to assess our capacities and also produce that document at the end of the day. So that will give us a very clear view of what is obtainable on ground and what are the gaps, and then where we need to invest. But prior to that, some preliminary, we have done some preliminary work actually to assess, our capacities. For instance, what are the numbers of oncologists that we have in the country, the number of nurses, the numbers of medical physicists and retired radiographers, which are also important in treatment of cancer using radiation. So, because that will inform, and there is a ratio, standard ratio between the number of cancer cases that you have in the country for each personnel or each category of this healthcare personnel that you have. We know that we are very far low behind what is recommended internationally, and also the number of equipment, the number of radiotherapy machines versus the number of equipment. So, but what is the government doing currently with respect to all these things? One, I have already mentioned, you need to actually assess properly to know what is on ground, which is what we are currently doing with the impact review mission. The other thing is, while this one is taking place, some things need to be done urgently based on these numbers that are coming out from the cancer reports. So the number of oncologists currently in the country is about less than 80 that we have. That is those that are trained in the art of radiation and clinical oncology. And we know with this JAPA syndrome, a large number of the oncologists are still moving out of the country. So there should be a way to produce more oncologists, and also a way to retain those ones that we are doing. So the National Institute for Cancer Research and Treatment has started engaging the postgraduate medical colleges, and also the National Sovereign Investment Authority. We are about to have an NICRAT NSIA Oncology Summit, which is going to address oncology workforce in Nigeria. And we are mainly inviting stakeholders that are involved in training of the oncology workforce, training for nurses, training for doctors, training for the radiographers, training for medical physicists. These are the major players in the space, because you need to find a way of addressing some of these problems. Apart from the numbers, for instance, the medical physicists are not registered in the civil service. There is no cadre called medical physicists in the civil. There is what they use is scientific officers. So there is need to also have a medical physics cadre and a career pathway. The cancer registrars don't have a career pathway. So these are some of the things that we also need to address. So
is that why they're exiting the country?
Not necessarily. There are several reasons why people exit this country, and I believe, for personal reasons or for maybe some personal gains.
In your own view, what would be the way to retain some of these oncologists?
Well, we have to first look at why they are exiting the country. It may be the remuneration, why they are exiting the country. So we need to actually find a way of compensating the oncologists. You can imagine you have less than 80 oncologists that will attend to almost 130,000 cancer cases. The ratio is very high. They are overburdened. There was a study that was done by one of the oncologists to assess burnout syndrome in oncologists across the country. The report of that finding was that all oncologists in Nigeria have burnout.
All right, so, but this applies also to other fields of medicine, and the solution. If the solution becomes that more people leave, it only, intensifies the burden.
Yes, so there is need to have some incentives for those working in the oncology space so as to retain them in the country. And also, oncology, work also entails probably going to, some of these remote places, because there is need for some people to go and do screening and other things. Right. So there is also need to put things in place that will retain those people even at the remote. All the oncologists that we assessed, even the less than 80 are in the urban areas. None is in the rural area. So another thing that also needs to be done actually is to subspecialization. The surgeons need to also subspecialize in oncology.
Right.
Also the gynecologists also need to.
Because we are running out of time. I hear you loud and clear, and I'm sure that those who are in position to deal with it are also listening, that subspecialization in oncology is very important. We have just a couple of minutes, and I hope we can get Professor Malami to give us his closing remarks. And perhaps you want to look at how, where you see cancer data collection, research, awareness, and treatment in the next, say, 2 years.
Yeah, thank you. We are privileged to work with a minister and a team currently, which is highly focused, are taking all the right places. Dr. Tunji Alausa has been an extraordinary force behind our success. And from October last year, when the National Cancer Control Plan was launched today, which is about a year, we have covered a phenomenal distance, to be sincere. We see ourselves in the next 5 years, which is our target. The 2027 would be the end of the 5-year plan. We see ourselves able to celebrate certain milestones. For instance, we are hoping that with the initiatives on cervical cancer, as you are aware, the minister has just constituted a committee headed by a very distinguished Nigerian, Professor Adeole, to lead the national effort to control cervical cancer. This is one of the major contributors to death due to cancer in Nigeria. And there is a WHO World Declaration to eradicate cervical cancer within the next 5 years. And that is by the year, 6 years, sorry, by the year 2030. And we see Nigeria being one of the countries that is going to be at the forefront of this fight with the formidable team that the minister has constituted. Not only that, we see an awareness strategy where the country will be creating a lot of momentum, creating passing the right messages, and this will transform the whole landscape in the sense that more resources will be mobilized, more resources will be deployed into cancer control in the near future, and this will make all the difference. We think.
All right, of course, we're looking out for all the difference being made, you know, by all those involved in this fight. Thank you so much, Professor Sani Malami, for joining us for the conversation. Director, Cancer Surveillance and Monitoring at NICRAT. We do sincerely appreciate you for your thoughts and insight on the program this morning. All right, of course, Professor Musa Ali Gombe, Director, Clinical Services, NICRAT. It was a pleasure to have you on the program.
Thank you for having me.
All right, so, and we hope to celebrate your successes with you in the next 5 years, like Professor Malami said. All right, so that's Good Morning Nigeria this Friday. Take care of your health, very important. I'm Henry John.
All right, I'm Victor Azu. Thank God it's Friday.